Picture a map of the body that lights up like a city at night. Each street is a nerve, each neighborhood an erogenous zone. Now imagine you are a curious scientist walking those streets, notebook in hand, studying how an adult woman explores herself, not to titillate, but to learn. This is a tale about pathology, about masturbation as a tool, and about the surprising geography of pleasure. We meet Dr. Lila, a researcher who once thought sexual health was a closed book. One critical case changed everything. An otherwise healthy woman, mid-30, who could not feel pleasure where everyone said she should. No obvious injury, yet her sensory map was quiet. Lila's first step was simple. She listened. Patients and volunteers described sensations in language as varied as weather reports. A spark, a distant hum, a tidal wave. Mapping those reports against nerves and cortical maps became the work bit. Pathology shows us the map's edges. Nerve injury, childbirth trauma, hormonal shifts, central sensitization, all can redraw the lines. The pudendal nerve carries sensation from the perineum. Small fiber neuropathy can make the clitoris or vulva numb or oddly painful. Central sensitization can turn light touch into sharp pain. Vaginismus is not moral failing. It is a protective reflex on loud. These are clinical stories, opportunities to treat and to learn. Masturbation in adult women is not mere recreation. It is self-directed sensory research. When done with curiosity, gentle variation of pressure, tempo, and area, it becomes a protocol. Keep variables clear: where you touch, how you touch, how long, what sensations follow. Track pattern. Does a low, slow touch wake dromedary? Does focused attention change cortical representation? Neuroscience tells us the brain is plastic. Repeated, mindful stimulation can remap sensation, reduce pain, and restore pleasure. That is not romantic wishful. It is neuroplasticity. Erogenous zones are everywhere and often surprising. Beyond the obvious glans and vulvar vestibule, consider the inner thigh, nipples, earlobes, the lower abdomen, even the inner wrist. Areas with overlapping spinal segments and rich cortical representation. Stimulating one site can recruit another. Crosstalk between regions can create bigger, richer responses. In some patients, indirect routes, breathwork, pelvic floor relaxation, or visualization unlock access when direct contact triggers discomfort. For researchers, the invitation is practical. Design small-scale experiments, pre- and post-intervention sensory map. Quantitative pain scales, heart rate variability during exploration, even imaging when possible. Ask reproducible questions. Which combinations of touch and breath reduce central sensitization? How does hormonal state shift threshold? How do cultural scripts affect self-exploration adherence? Finish with a thought experiment. Imagine teaching an adult woman to become her own clinician, a participant in her sensory study. She logs sessions, notes, and reports back. Over months, the quiet nap brightened. Pathology remains a teacher. It points to mechanisms, and masturbation becomes both method and medicine. A safe, controllable probe into the body's circuitry. So pick up the notebook. Map, test, iterate. Pleasure is data. Curiosity is the method. The body has stories to tell if we listen like scientists and act like careful, imaginative clinicians.